I'm Josh. I'm at NYU. It's great to be in Denver. I came to medicine kind of not knowing what exactly I was going to do. I did a primary care-based residency, and probably might have gone into psychiatry, but didn't. I was looking around for research options because I like to write stuff like that, like numbers, maths, biostatistics. That worked out pretty well. It's what I wound up doing, clinical research for most of my career. But addiction medicine was kind of becoming a thing, and that's kind of the theme today, that you didn't, in medicine it was really in psychiatry and then addiction psychiatry where people treated addiction. But we were in the midst of the kind of pill epidemic, rapidly becoming the heroin epidemic. There was a growing understanding that a primary care doc, a nurse, a PA, a pharmacist, all these people could do really good, important, effective stuff for alcohol, for smoking, and then for opiates as well. A lot of that's based on the medication, but a lot of it's also just based on kind of like that patient there, the young, pissed off heroin kid in the ED. If you can just kind of talk to the person, and not be super judgmental, that can be, a powerful thing in these cases. And any of us can do that. We're all smart enough. We are all articulate. We all kind of understand the kind of basics of addiction, how it works in the brain, how people just kind of get stuck on a substance, whether it's, cigarettes, less stigmatized, or heroin. The approach is very similar. We have good medications for tobacco, not only nicotine replacement stuff or switch your adult smokers to e-cigarettes, but I'm talking about Chantix, or older was bupropion, Wellbutrin. Those all work better than placebo. That is, if you can get more and more patients to try Chantix, you will wind up getting more and more people to quit smoking. The same principle is at work with alcohol and opiate disorders. We have really good medications. If we can prescribe them, and you can prescribe all of them, to more and more patients, get them access, get them kind of continuity of care, help them take them over the course of months and months and then years and years in many cases, they will do a lot better. We'll have fewer overdoses. We'll have more people kind of raising their kids rather than the kid being in foster care. We'll have more people, being productive and healthy. And they may not all quit. One of the harm reduction principles is you're probably going to keep using some drugs and alcohol, and I'm not going to lose any sleep over that. When that kid's in the ED having just overdosed, I don't really care how much Xanax he uses in the next year. It's not great for his health if he's, using a lot of Xanax, and it's not great for his overdose risk if he continues to use a lot of Xanax with the opiates. But what is going to kill him in the next week, and he has a very high risk of a second overdose because he just had a first one, is to continue to use the opioids, especially if in his community they're laced with fentanyl. And so starting treatment immediately in that case, and then continuing it in the first week and the next week after that, and kind of got to see how it goes with a medication like methadone, naltrexone, or buprenorphine is the way to go. And we can worry about like the Xanax, or that he's a smoker, or that he drinks too much later on down the line. And we may not fix all that. These tend to be kind of complicated patients, but that's okay. If we're kind of reducing harm, we're also kind of just dialing down the chance of death and all the harms related to the opiate use, much like I can't give everyone with a blood pressure of 170 over 120. They're not all going to be 110 over 70 for the rest of their life, if only they do, what I recommend, and take these 3 pills and lose some weight and stop smoking, blah, blah, blah. But as you get their blood pressure down to 140 over 86, say that's their average for the next 10 years, that is a ton better than 170 over 120. The relationship to stroke, cardiovascular disease, sudden cardiac death is directly proportional to your mean arterial blood pressure, or to your systolic blood pressure. So the higher, the worse. And if you can get it down a little bit, even though you're not at goal or totally kind of sober, say, in the addiction context, you're still doing a lot in terms of harm reduction and kind of the net benefit of all this stuff. So another kind of harm reduction principle is a little opposed to what we traditionally taught in addiction was you had to be in recovery, you had to put down the alcohol, you had to go to 90 AA meetings in 90 days, and that was the only way to kind of be sober. We've learned that that's just not really applicable to many patients. They're not really signing up for, I'm never going to use drugs and alcohol for the rest of my life. But they will sign up for, yes, I'd like some effective treatment for something that could otherwise kill me week to week, like my heroin use disorder. The best, biggest studies we've done, for instance, for alcohol treatment, used a medication, oral naltrexone. We were just hearing about at Denver Health for alcohol. Cheap, generic, 1 pill a day, very easy to take, minimal side effects, pretty well tolerated. Doesn't work for every drinker, but it works pretty well for a lot of drinkers. And in that study, it was really, there wasn't a complicated medical team, it was more like a pharmacist-driven intervention. So you'd get the pill and the pharmacist would kind of give you that same pep talk. It'd be, hey Josh, how's it going? Take the pill, I'm encouraging you to do that. Let's troubleshoot any problems you have. Getting the pill, storing the pill, remembering to take the pill. Medication adherence is, just like in every other chronic disease, a big part to play here. And then, good, that's great. Now, drink as little as possible. That's kind of the goal of being on this pill. But, if you had a drink here and there, we're not, kicking you out of the treatment or anything like that. And over time, that intervention, a kind of pharmacist pep talk on a weekly, bi-weekly basis or every month, when you get your refill, and then the medication, the access to this medication that goes into your brain and changes how you think about alcohol, was as powerful as anything else tested in that study. This is the combined study from 2006. It was the largest and very complicated NIH-driven alcohol treatment trial ever at the time. And it showed that very simple thing, and this medication that we knew quite a bit about but hadn't done a study that big with to date, was better than that plus all this extensive individual kind of psychotherapy. That plus another medication for alcohol, it didn't give much additional benefit. And the bottom line was a very simple, accessible, cheap way to kind of support medication use was the most powerful intervention for alcohol, for helping people reduce heavy drinking, reduce the harms related to alcohol. And the same stuff is happening in opiates. So you do have to work in a methadone program, and you're all welcome to do that, to get methadone to patients on a daily basis for opiate use disorder. That remains a kind of highly regulated, kind of sequestered treatment system. It's a great one, but it's kind of stuck with those regulations. But buprenorphine and naltrexone can be prescribed in specialty care if you're at a behavioral health center or addiction treatment center. They can be prescribed at the FQHC in rural America or the FQHC in urban America, in a private office, in a big practice, in an academic, in any other setting. So that's kind of the new wave, and I highly encourage people to, as we just heard, do the X training when you do get your DEA. It's the next additional step. They're making it free and pretty easy to access that stuff. A lot of it's online now. And I'll tell you the last thing. Did you see that patient? He was kind of annoying at first. He was really resistant. He was pissed off. He had just gotten woken up from about to die, but also probably feeling pretty great with all the heroin that he took. They were going to, through fits and starts, have a breakthrough there, and he was going to access treatment. But what I noticed about him was he was young. When you do addiction medicine, addiction psychiatry, or substance abuse treatment in any setting, you'll be treating some older people, but a lot of young patients, and that's great because if you fix them or stabilize them, they don't have a ton of other health problems, and the rates of progression a little less accelerated, but very few other kind of 30-year-olds are walking into primary care with a kind of life-threatening thing that you can fix in a pretty simple, direct way, and then lo and behold, the person doesn't have that many other health problems, and it's great. And then the other thing with buprenorphine especially, if you want a patient to come back and see you when you say they have to come back and see you, how do you do this in medicine? You prescribe them a controlled substance. That's the key. Yeah, I learned this over the last couple of years. If you want to be the Oxy doctor or the Klonopin doctor, those patients will always come back to see you because they need the refill and they are on those medicines, often problematically. And then this is the case of a good controlled substance. Buprenorphine is a Schedule III drug. But they're not just going to be able to go anywhere to get a refill. They're going to keep coming back to see you because they knows it works. It makes them feel good and normal, as opposed to kind of out of control and up and down. And you're the cause of that. You're the hero, and it feels good. And they'll come back and see you because they need a refill. All right.